Bismillah ar-Rahman ar-Rahim. In this lecture, we are going to discuss DCIS from the perspective of breast radiologists attending the MDT. We're going to answer 4 questions. How do we characterize calcifications? Next, what should breast imaging radiologists know more about DCIS? Third, radiologists and pathologists in the MDT usually ask each other, are our results concordant or discordant? And how do referring clinicians want radiologists to report DCIS? And while answering each of these questions, we're going to give some common clinical scenarios that we encounter in the MDT. We'll start by the first question: how do we characterize calcifications? To characterize breast calcifications, we should describe the morphology and the distribution of these calcifications. As for the morphology, we have a long list of benign and a long list of suspicious calcification. One common feature which combines benign calcifications is that they are all macro calcifications, which means that we see them without the need of a magnification. And one common feature which combines suspicious calcifications is that they are all micro calcifications, and that means that we need to do magnification to see these calcifications. As for the distribution, the distribution might be diffuse, regional, segmental, linear, or grouped, or what we used to call the clustered microcalcification. And going from the right to the left to the right, we are going from benign to malignant calcifications. And now we're going to see some common clinical scenarios. This is a screening mammogram of a 55-year-old female. She has bilateral rod-shaped calcifications seen in both the mediolateral and the mediolateral oblique view. In between these macrocalcifications, although they are evident, we saw this focal asymmetry with clusters or grouped microcalcifications within. With adjacent, this is vascular calcification. The biopsy came back with a low-grade DCIS. Do you agree with this? منال يعني ردوا عليا شجعوني. You agree? Actually, when we saw the case in the MDT, we did not agree just because the patient had a pathological axillary lymph nodes, and DCIS does not give pathological axillary lymph nodes. So we went for a lymph node biopsy, and this was a metastatic lymph node, and actually on surgery, this was a mixed invasive duct and invasive lobular DCIS. Next, we're going to see what should breast imaging radiologists know more about DCIS. DCIS cases presenting to the radiology department are usually asymptomatic patients referred from the screening units. A portion of the DCIS cases are symptomatic patients coming from the outpatient clinics, complaining mainly of nipple discharge, and characteristically this nipple discharge is unilateral, uniorificial, spontaneous bloody nipple discharge. A portion of the DCIS cases might come with a palpable mass lesion. If you ask any radiologist or any clinician about DCIS, he will tell you that the vast majority of DCIS manifest as coarse, heterogeneous, fine pleomorphic microcalcifications, either taking a grouped or a clustered pattern or a linear branching or segmental pattern. What we should know more about DCIS is that not all DCIS present with microcalcification. About 10 to 25% appear as a non-calcified asymmetry, like in this case. This is the contrast mammogram of the same case, showing a very faint contrast uptake corresponding to this subtle asymmetry. Also, some DCIS might present as a non-calcified mass, like in this case. There is a small mass in the left upper outer quadrant, and it is a non-calcified DCIS. What we should know more about DCIS also is that multiple lesions can occur in the same breast or in the contralateral breast as well. For example, we have this case. There's an evident focal asymmetry in the upper outer quadrant showing microcalcifications. If we do not look closely inside the breast, we would miss another small DCIS seen in the inner breast quadrant, and definitely managing a multicentric disease is not like managing a unifocal disease. So this was a multicentric DCIS. Microcalcifications are truly seen on mammography, and that is why most DCIS cases are detected in mammograms. But the question here, do we see them on ultrasound? And the answer is yes, we see microcalcifications on high-quality ultrasound machines, and there are some applications on some of the machines in which we apply to highlight microcalcifications. Microcalcifications can appear within the parenchyma and sometimes within the ducts, and if we apply the Doppler and we see additional vascularity, then we are more sure that there is a DCIS or a malignant lesion within the duct. But what if the DCIS is not calcified? Again, we should ask ourselves, could we still identify them or no? And again, the answer is yes. Non-calcified DCIS may appear as non-mass hypoechoic areas, and sometimes they appear as dilated ducts showing echogenic content with marked vascularity on Doppler application. Definitely, MRI is the modality of choice when we have a diagnosed case of DCIS to assess for the extent of the disease. This is an example of a case with subtle changes seen on the mammogram with microcalcifications. Look how they appear on the MRI. We can say that we have a segmental non-mass enhancement extending from the nipple, and we can measure the actual extent of the disease. So to set up some rules in diagnosing DCIS, because DCIS follows duct ramification, any calcification or enhancement pattern taking a specific distribution in the breast should be taken seriously. This is an asymptomatic patient. She came for screening in 2021. She had this evident mass in the upper outer quadrant on ultrasound. It turned out to be a cyst, and this cyst was a complicated cyst which was aspirated, and she was asked to come for the next year for screening. She came in 2022. The cyst is not seen, but what she developed new in the 2022, she had left breast microcalcifications, and no one could see these microcalcifications until we magnify. Now we can see the multiple groups of microcalcifications seen in the upper outer quad. We compared the AI in 2021 and 2022, and AI is very sensitive to microcalcifications, and definitely these calcifications were not present in 2021, and they were newly developed in 2022, which further raised the suspicion. A vacuum-assisted stereotactic biopsy was performed, and whenever we do a biopsy for microcalcification, we should image the specimen and make sure that the specimen contains these microcalcifications. Also, the pathologist should document in his report that there is calcifications within the specimen to ensure that we took the biopsy from the correct space. And the biopsy report came back with an intermediate grade DCIS. We move to the third step, and that is that when we are sitting in the tumor board, usually pathologists and radiologists ask each other, are our results concordant or discordant? Radiology pathology correlation is the ultimate phase in the diagnostic workup of any patient, after which management decision is taken. It includes the critical review of the imaging findings in view of the pathology report. We have different situations of pathology, radiology, concordance and discordance. First, we can have a concordant benign, and that's from the point of view of radiologist, we say it is benign, and the pathology comes back with a benign pathology, and in this case, the patient should be put under a follow-up. We have concordant malignant results. We say it is malignant, and the pathology report says it's malignant, and in this case, we have to proceed for radical management. Sometimes we have discordant benign results, and from the point of view of radiologists, this means that we say it is benign, but the pathology report comes back with a malignant pathology. So we have to discard what we said about the case, and we have to proceed for radical management. We have another fourth condition, the discordant malignant results. We say it's malignant, but the pathology report comes back with a benign results, and in this case, we should take a stop and revise ourselves. There is also another situation, if we both say it is malignant, but what we see in the imaging is not explained but by the pathology which comes back in the pathology report, and I will show you cases of discordant malignant results. Although we and the pathology said it is malignant, yet it was not discordant to each other. And in the last two conditions, we should have a stop, revise ourselves. We start by re-evaluating the imaging features. See if the lesion was correctly biopsied or no. Should we re-biopsy or excise? And do we need larger core biopsies or no? We're going to see some common scenarios. These are discordant, an example of discordant benign results. This means we said benign, but the pathology came with a malignant report. This is a 42-year-old complaining of right bloody nipple discharge. This was her mammogram. She had a heterogeneous dense breast parenchyma. No microcalcifications or speculated lesions were seen. On the ultrasound, there was this tiny lesion, and in the ultrasound report, it was written that this is a retroareolar avascular mass lesion with related dilated duct, likely intraductal papilloma. A cytology examination of the nipple discharge was performed, and the pathology report said that there is mild to moderate atypia, and when we see atypia, we should revise our results. In the MDT, when we saw the case, I told them, no, this does not fit with the diagnosis of an intraductal papilloma. Yes, there is an adjacent dilated duct, but this is not an intraductal lesion, and this does not fit with an intraductal papilloma. So we had to re-biopsy the case, and the biopsy showed low-grade DCIS of cribriform pattern. It was positive for ER, and this was a marker that is made to ensure that there is no invasion. So the biopsy report came with a low-grade DCIS. And immediately in the MDT, when a DCIS is diagnosed, the surgeon will ask the pathologist, the radiologist, I should proceed to radical surgical management, but what should I do? Should I do a conservative surgery or a mastectomy? And in this case, we usually need to proceed to another, more advanced imaging modality. And as I told you at the beginning, the best modality is MRI. And as we see in MRI, this is the small mass that was seen on ultrasound, but it was associated with dilated ducts and segmental non-mass enhancement extending from the nipple down to the pectoral muscle, and the management decision in this case was simple mastectomy. This is an example of discordant malignant results, which means we said malignant, but the pathology came with a benign result. This is a screening mammogram of a 65-year-old female. She had a small obscured mass lesion in the left breast, and it was, on ultrasound, it was a cyst. But there was a more serious finding in the right breast, and we cannot see this serious finding unless we do a magnification to the right breast. And again, we see that there are microcalcifications extending down to the nipple. A biopsy was taken, and the biopsy report came with an intraductal clonal epithelial cell proliferation with cytologic and morphologic features similar to low-grade DCIS, but it only involves a portion of the affected duct. And the pathology report, in the conclusion, they said it is fibrocystic disease with foci of ADH. When we saw this, we said, no, this is discordant with what we saw on the mammogram, and we should revise ourselves, revise the imaging features. The imaging features were typically malignant. Was the lesion correctly biopsied? And this was the question. We looked at the specimen that was imaged. Only a single fleck of microcalcification was included in the specimen, so this was an inadequate biopsy. We asked for a rebiopsy using vacuum-assisted biopsy. There were microcalcification now in the course, and this time the pathology report, in the pathology report, it was written that this was an intermediate grade DCIS of solid and cribriform patterns with microcalcifications. And again, the pathologist should document in the report that he saw calcification. Lastly, we come to how do referring clinicians and radiologists want us to report DCIS. The radiology report actually is considered the end product of radiologists. They are the chief way how radiologists communicate with clinicians. On the other side, clinicians are considered the customers of the radiology department. Before attending the breast cancer tumor boards, radiologists are usually product-centric, which means that during writing the report, they mainly focus on a well-organized report, which is their product, irrespective of what the clinicians or the customers' demands and challenges. While after attending the breast cancer tumor boards, they become more customer-centric, which means that we focus on the clinicians' demands and challenges while writing the report. I'll show you an example of the difference between a report written by a product-centric radiologist and a customer-centric radiologist. We have this 38-year-old with left breast palpable mass, which was diagnosed as inflammatory outside Bahia. When she came to Bahia Hospital, there was a global asymmetry of the left breast, and on ultrasound there were scattered microcysts, dilated ducts, and indeterminate axillary lymph nodes with cortical thickening. The biopsy of this case turned out to be a high-grade DCIS. A product-centric radiologist will just write left breast global asymmetry seen in both the CC and MLO view, and there are left axillary lymph nodes with a thick cortex, and he would stop to that extent. But if you know what the clinician needs, you will write something more than this. You will write, yes, there is a highly suspicious left breast global asymmetry with parenchymal distortion seen in both the CC and MLO, but what is more that we should add that it measures X by X centimeters, being approximately X centimeters from the nipple and X centimeters deep to the skin, because all this will help the surgeon to choose the correct surgical technique. And we should mention that there is no skin thickening, and there are associated indeterminate level 1 axillary lymph nodes. When we see the lymph nodes, we should specify the number and the level of these axillary nodes, and we would recommend a biopsy from these nodes. And when in the MDT, he knows that the lesion pathology report is a DCIS, he would not accept this with an indeterminate axillary lymph node, and he would recommend also for further contrast study and the second look ultrasound on the left axillary node and biopsy. The patient performed MRI, and again, a product-centric radiologist will just write that there is a left breast segmental heterogeneous numb mass enhancement. It shows a dark T1, intermediate T2, and bright signal and with restricted diffusion, but a customer-centric radiologist would mention the size of this numb mass enhancement, the distance from the nipple, if there is nipple invasion or no, the distance from the skin, and if there is skin invasion or no. And lastly, the implementation of multidisciplinary tumor boards enhances the communication between different specialties, and thus they definitely impact breast cancer care outcomes from diagnosis to management. Furthermore, multidisciplinary tumor boards are a good chance for young radiologists to learn and for professionals to upgrade their knowledge. And thank you.
Thank you, Dr. Rasha, Professor Rasha. Thank you. Any questions?